Good evening, folks. It's David Rawson, founder and president of this academy. Welcome you all again to another webinar. Tonight, I'm very excited to be introducing Dr. Stasha Gominack, physician who's now in Texas. Her topic is 3 simple steps for a healthier sleep. You've got a number of copies of our announcement. The learning objectives are there. I simply want to highlight her bio by reading the following. Dr. Gominack grew up and attended college in California, moved to Houston for medical school at Baylor College, where she received an MD in 1983. Her neurology residency was done at the Harvard-affiliated Massachusetts General Hospital in Boston. She practiced neurology in San Francisco Bay from 1991 to 2004, and then moved with her husband to Tyler, Texas. Starting in 2004, she began to dedicate more of her practice to the treatment of sleep and sleep disorders. In 2012 and in 2016, she published 2 pivotal articles about the global struggle with worsening sleep, the possible causes and solutions related to vitamin D deficiency and the intestinal microbiome. In 2016, she retired from practice to have more time to teach. She currently divides her time between the right sleep coaching sessions for private individuals and teaching other clinicians the right sleep method of sleep repair. As I said, Dr. Gominack is speaking tonight on 3 simple steps for healthier sleep. And I turn it over and welcome to Canada, Dr. Stasha Gominack.
This is so pleasant. I don't even have to go out in the cold. So thank you so much for inviting me. Most of the time when I start this lecture, I ask a few questions of the audience. So I'm not going to do that this time because it would be hard to answer. But I want to open the discussion by saying that the sleep dentists have taught me so much. And I don't want you to think that anything I'm going to tell you about it is intended to say that what you guys are doing is not important, because it's really important. So there's a very important aspect, which is the anatomy, the airway, and that's what you guys are good at. And you've taught me a huge amount about that. I want you to think instead about the patients who you feel like you have done your very best, and they just aren't sleeping as well as the ones that you have great success with. I want you to think about the ones that keep you up at night, where you thought, I wonder what else is going on. You know, I know about CPAP. I really didn't think this person needed that. And I've tried the other interventions that I have available. You guys know that and have taught me about it. We're not going to do that part tonight. What we're going to do tonight is talk about the biochemistry of the brain and how the brain takes over and runs the oral airway while we're sleeping. I offer courses to learn this more in depth. We're going to cover a lot. This is really an introductory lecture. So we're going to jump off with the concept that it's kind of weird that lousy sleep is the new normal. And I don't think it was always this way. I think you guys are miracle workers, and you have taught me an immense amount about mouth breathing and what you can do to help with facial development and oral airway. I myself am using Invisalign type movement on my teeth to try to get more space, because I had 4 teeth taken out when I was a teenager. So the person I want you to focus on is the one who you've already done your job. And this person has a perfectly good airway, beautiful teeth. You know that the airway opening size is good, yet she's coming to see somebody else because now she can't fall asleep. What else could be going on here? So is it only the oral airway that is affecting our sleep? And I'm going to try to introduce you to another way of thinking about it. And the more tools we all have, the better the outcomes we have. So it turns out that really our sleep is linked to 2 clocks. You guys have been taught about the circadian rhythm, which is the 24-hour clock, which is actually also connected to something called a vitamin, which is one of the retinoids. So light going through the eye, through the retina, links to the pineal gland and links us to the 24-hour clock. But there's a second clock that has been, unfortunately, embarrassingly, ignored by the endocrinologists of medicine, and that is the annual 365-day clock. And there is another thing that's actually a hormone that's made on our skin from exposure to the sun that links us to the winter-summer cycle, which allows us to hibernate in the winter. And this is the part that I think has really changed things in the last 40 years. So since the 1980s, we've had sunscreen, computers. COVID has exaggerated this even more. We as a species have moved indoors in a way that is not natural for our biology. And our biology doesn't actually keep up with our habits. Our biology just stays the same. So we're going to trace how this is actually produced this problem. And I'm going to give you the 3 steps that I want you to think about right at the front. So the first is, even though you've done all these things with the oral airway, the brain takes over the oral airway and it paralyzes it while we're sleeping. That's why we're calling this sleep apnea or sleep disordered breathing or sleep disorders, because it's while we're asleep. And it turns out that vitamin D runs our sleep at the brainstem level. And it also turns out, surprisingly, that the microbiome or the bacteria that live in our intestines actually runs our sleep as well. And if you have low vitamin D, this is particularly pertinent for Canada, you actually lose your microbiome as you keep your D low for several years. So most of the population in Canada also has the wrong microbiome. And that means there are several things that are related to microbiome production that your brain is missing when it's trying to sleep. So how did I happen to be here? I'm not head of the Stanford Sleep Study Center. I actually didn't have any formal training in sleep when I started this, which to some extent, I think was an advantage because I was completely naive and I just listened to my patients. I personally believe that there are lots of moves forward in medicine, and I include dentistry as part of medicine, that happen by clinical observation. So despite this term evidence-based, I think that actually seeing patients is a form of evidence. So this is the story of how I wound up here, trying to spread ideas. So the first event was that I actually had a patient who demanded a sleep study. And this was 13 years ago now. And she, actually more than that, it's 18 years ago now, almost 17 years ago, she demanded a sleep study for her daily headache disorder. I had given her several of the medicines that I'd found successful in the past. They hadn't worked. That's not unusual. Daily headache patients have a lot of problems. They don't really get better and stay better. That's why I had so many of these patients in my practice, and they're very discouraged. I'm discouraged. We're pretty much willing to try anything. So she said, my husband says I snore like a train. She was young, healthy, did not have a fat neck. She was not in the population that we were being told that we should do sleep studies on at the time. And keep in mind that things have changed a lot over that period of time, but she had sleep apnea. She put on a CPAP mask and her headaches went away. And for me, that was mind-boggling. She couldn't even put her hair in a ponytail because her head hurt so much. That meant to me that this is not likely to be a placebo effect. She's wearing a CPAP device, and within a couple of months, her headaches go away. I am personally very biochemically minded. That's the way I think of things. She had apnea, but she had no drops in oxygen. And what we were being sold at the time was the logical story that the pulmonologists made up. So the pulmonologists were left with the patients with apnea. So they make up a story that fits with the way they think, and they think about oxygen. But I'm a neurologist, and I know that people who have a brain that's starved of oxygen get strokes. So in this case, 1, she didn't have any drop in oxygen, and 2, I don't think a drop in oxygen is the explanation for why she has daily headache. My explanation was, oh, this thing that we're blowing air through her nose is stenting her airway, allowing her to stay in the deeper phases of sleep longer. And oh, maybe she's making a chemical that's better than my drugs that her brain has been using all along to shore up her genetic weakness, because migraine is now known to be a genetic disorder. There are about 300 different mutations. They're all channel disorders, sodium channels, calcium channels, and sodium potassium ATPase channels. That means there are chemicals that the brain could make if it had time in deep sleep. This was my little legend or my story that I was making up. So I made up a different explanation for why it was that this particular patient had resolution of her headaches by wearing a CPAP mask. Now, as I told you, these patients are desperate and they're willing to do almost anything. And actually, many of them are very willing to go and do a sleep study because they are tired. So there was a population of young, healthy females who've had a couple of kids, who had daily headache and were tired and depressed and had other pains. That was about half of my practice. So I started busily doing sleep studies in anybody who would let me. So the ones that had sleep apnea, which was relatively rare, I could send to my pulmonologist buddy to get him to put a CPAP device on. But most of them did not have sleep apnea. These are keep in mind that these might be younger, earlier disease. So most of them did not have apnea. However, what I learned over time was, because I was using these sleep studies and talking to my pulmonologist, was that they actually had a slightly different result on their sleep studies. But it took a while because it wasn't on the report. And again, this was several years ago. Now, most of the study reports I was getting said no significant apnea, but they didn't mention the fact that they didn't have any REM sleep, or they had REM-related apnea, or they had very abbreviated REM sleep. So rapid eye movement sleep was not being mentioned on the front page. And I finally talked to my pulmonologist about the fact that I was sending in 20 sleep studies a month and more. And he said, you know, the population you're sending to us is very different than the usual population. And I don't know if you've noticed this, but your patients have a consistent effect on their REM sleep. And I said, oh, no, I haven't noticed that. And he said, yeah, they have REM-related apnea. And I said, well, Chuck, what is that? And he said, oh, well, they just stop breathing in REM sleep. And I said, well, why would that happen? And he said, well, we get the most paralyzed of all in REM sleep. And I thought, wow, paralyzed. That's creepy. And it's also creepy that I haven't been discussing this with my patients. So apparently this is on page 2, where they're summarizing the amount of these various phases of sleep. So now I have to learn how to read the sleep studies. And quickly it becomes obvious that this particular group of young, healthy, mostly females, now I'm doing teenagers, kids, have little or no REM sleep. They certainly have less. And if you only have a half an hour of rapid eye movement sleep, and you're supposed to have 2 hours, and that half hour is interrupted every 5 minutes, then you get a sleep study report that says no significant apnea, because they break up those 6 to 8 apneic episodes into 1 per hour. Well, that still means that the REM sleep that she got was very interrupted. So there were these consistent findings. My pulmonologist pointed out that we get paralyzed in sleep, which frankly was very creepy. I really felt like, wow, that's bad. How do we get paralyzed and not, how come we don't drown? Like, we have to swallow, and it turns out we only paralyze the oral airway in rapid eye movement sleep. Well, that seems to me to be a neurology problem. Like, the area of the brain that decides when we go into REM sleep or we go into slow wave sleep, into these deeper phases of sleep, is really in the brain. That's not in the lungs. So the pulmonologists have been asked to explain what's going on, but in actual fact, this should be a neurology problem. So the oral airway has been our focus for the longest time, because we were actually looking at the most severe population. In the very beginning, it was post-operative heart disease, bypass surgery in the post-op area where the nurses are seeing that these people are sitting upright and they stop breathing when they go to sleep. And that's, you're going to call the pulmonologist for that. But in fact, getting paralyzed during sleep is an extraordinary thing. And when you think about how you would have to engineer that in order to make it successful without killing us, and if you think about the fact that this has been working successfully in more animals than we can count for millions and millions of years, then you begin to understand that we just failed as a species in something that has a perfectly operating engineering diagram in all the other species on the planet. So this makes you look at it in a different way. Now, if I am going to look at this sleep switches or the area that makes us paralyzed as an engineer, then obviously, if you're going to paralyze this living thing, you have to be able to make sure it doesn't die while you're paralyzing it. And we had actually seen what happens on these sleep studies. So this is a mock-up of where the electrodes go in the sleep study. And what we see when someone is being monitored, there's an EEG pattern that's on the scalp. Then there's a little monitor in the nose that does airflow, and then there's electrodes attached to the chest. And as you can see here, there's a section where the airflow is stopped and the chest wall is really working, and this is the sample of apnea. But what you don't see, or what they don't tell you, is it's not the technician who runs in there and says, "Mr. Robbins, wake up, you just stopped breathing." It's his own brain. There's an arousal that happens. The brain has seen that he stopped breathing and woke him to lighter sleep. So what we're really seeing with apnea is that the person stays in lighter sleep where they're not paralyzed. And every time they try to get into a paralyzed phase, they stop breathing and are awakened. And that's very severe disease. So these are the phases in which we get paralyzed. We get paralyzed in slow wave sleep and we get paralyzed in REM sleep. And they have a different chemical footprint. And we actually progress through the night by moving from light sleep to a deeper light sleep and then into slow wave sleep. And then we move to lighter sleep and then we do REM. So we do these blocks of paralyzed sleep in small blocks that are usually much less than an hour, partially probably so we won't hurt ourselves by staying in the same position. Now, where does this happen? Where is this paralysis happening? Is it possible that if we learn about the control system that's doing this, we might learn something that would help us figure out how to, one, look at how we transition through the phases. Since my patients don't have apnea, it doesn't make any sense for me actually to be sending them. At the time, I didn't know anything about sleep dentistry, so I would have been sending you a lot of my patients. But because they didn't have sleep apnea per se, I couldn't use a CPAP device. So what I'm using is sleeping pills. And we all know they're not very successful. They're not bad. It's the wrong idea to vilify them. They are a patch. They are a Band-Aid, just like CPAP. But it would be nice if we knew more about who's running this. Why are we getting too paralyzed? Why are we the only animals on the planet that are wearing these CPAP devices? So the sleep switches are in the back of the brainstem, and there are two very basic functions. Clock, which means that you never get paralyzed while you're sitting here talking to someone. You only get paralyzed while you're asleep. So these are sort of like breaker switches where they're connected and they're all supposed to flip together. Now, as soon as I say that to you, you should realize that there are people that you're seeing in your practice who actually have sleep switches that are not flipping together. So they have these odd experiences where most people, in fact, the system was designed so that you could only be asleep or awake, but never both. This is very old. Dinosaurs have a brainstem that is just like ours. It's called the reptilian brain. There's been little in the way of change. That means that dinosaurs lived on this planet longer than we have with perfectly normal sleep, and they did not get sleep apnea. So the next question would be, why would our paralysis switches start to goof up? And I start to explain to my patient that there are these switches in the brainstem. Of course, they have to listen to me because I'm their doctor, but this could mean that one specific area that can turn off all of your muscles must be able to turn them back on again. And that could then explain stopping breathing because the oral airway gets too paralyzed, and leg movements that nobody has an explanation for. So it could explain that if you got too paralyzed, you'll lose in the oral airway. If you get too paralyzed in your limbs, you were supposed to be completely paralyzed there anyway. But if you don't get paralyzed enough, then you could have walking movements of the legs, bruxism, acting out dreams. So it's one area, but it could explain several findings on the sleep study. In order to understand how neurology works on a very basic level, you have to understand that when I'm keeping my arm in this middle position, my electrical pulses are being used. So instead of the electrons moving in a continuous band like the wires in the wall, I'm actually trying to keep my arm in the same place by firing an up message at a certain rate and firing a down message at a certain rate. And I'm matching them so that I can keep my arm in the same place. That means firing rates are how we keep this paralysis. Now, because I don't have anybody writing about this, so I'm looking at all the literature saying, why isn't anybody talking about how headaches are related to sleep and how all my patients who are completely healthy, as far as I can tell, they're not on drugs that I can blame this on, do not have normal sleep studies. And if I look at the literature around the world, every place that has sleep study centers now between 2005 and 2010, they all have abnormal sleep. That means this is a global phenomenon. Because I don't have any choice, I'm looking at these nerdy articles that are about firing rates in dopaminergic pacemaker cells in the brainstem. So I'm actually finding scientific studies that are about how often are these dopaminergic cells that are really the clock function of our sleep switches, how frequently are they firing? And there are these really nerdy articles about dropping these neurotransmitters on. You drop norepinephrine, it goes a little faster. You drop acetylcholine, it goes a little slower. And I realized that this guy who's got a hair-like electrode, this tiny little electrode in this one cell in a rat brainstem, is actually writing about what is happening to my patients, because those neurotransmitters are not perfect. There's a wobbly paralysis switch. And now I'm thinking, okay, this is more than just airway. It's the airway and the brain, and it'll be more of one than the other in some people. So I'm thinking about it in a different way. So we really have two questions. In your field, you're focusing on the opening itself, and you must do that. And I'm thrilled that you're there. But while we're sleeping, the brain actually paralyzes the oral airway. And then there are two issues. Do we have the proper neurochemistry to achieve deep sleep and to get paralyzed correctly and stay in those phases long enough to complete our processes of restoration and feeling better? And the second is, while we're paralyzed, is the opening big enough? So we really need those two pieces both addressed. And what if these patients who are 30 years old, who are constantly saying they have knee pain or ankle pain or toe pain, they really are 30 years old, they really shouldn't have any pain. What if, when I'm looking at the sleep study and I'm seeing that they have these walking movements, so the periodic limb movements of sleep are periodic and they alternate because they are related to an ancient walking nucleus that is in this same part of the brainstem that is supposed to be completely suppressed. So when your brainstem switches are not working correctly, there are certain parts that are suppressed too much, other parts that aren't suppressed enough. And maybe if we learn more about this area, we could actually fix this. So that's the way my brain is working at the time. So the thing that's really unique here is I'm thinking about sleep as a single cell. That is not something that most of us do. So I'm thinking of it in that way, and the firing rate of that single cell, and some of them are pacemakers, which means they're a time clock. Some of them are paralysis cells that come into play when we're sleeping. And then here's what happened. I have a clinical event where I have this beautiful 18-year-old girl who's just about to go to college, and she'd seen me for daily headache. We'd put her on a medicine, the headaches are better, but she comes in and says, I'm so tired. I sleep fine, but I'm terribly fatigued. And I know that you hear that all the time. And I have her sleep study in front of me. She has 10 hours of sleep, goes to sleep, sleeps through 10 hours. As far as she's concerned, she sleeps fine. What we see on the sleep study is she wakes up 35 times an hour. No apnea, no respiratory related. In the current state, I'd be wondering about her nose, but at the time I knew nothing about that. She had no deep sleep, and she turned out to say, is there any tests you could do for my fatigue? And I'm looking at her sleep study going, this is horrendous. I don't know what's wrong with her, but she's going to be seeing me in the hospital with a stroke in another 10 years. I mean, this gal is aging faster than the other people around her because she has absolutely no deep sleep. It turns out her B12 level was quite low. So B12 is well known to have to do with sleep, and it's got plenty of articles about it. Most of the time we focus on how's your energy, but going to Google just produced what are the symptoms of B12 deficiency, because I had never done a B12 level in a headache patient in my life, and I'd been doing headache for 25 years. So I go to Google, and Google says, symptoms of B12 deficiency, fatigue, and daily headache. Well, the weird part about that is daily headache B12 connection is not in the neurology literature. It's in neurology under B12 deficiency. But if you look under how do I learn about headaches and treating them, treating for vitamin levels is not addressed. And at the time, there weren't even any hits between headaches and sleep. So sleep disorders were not considered to be one of the predisposing causes of headache, though now there are a lot more articles about that. So because I'm thinking of this as a single cell, for the first time, I think, I don't even know about B12, but I know that it's one of the pivotal pieces of that energy metabolism and repairing that cell. So maybe our sleep switches are firing and wobbling around because they don't have this necessary part. So the very first time that I ever thought perhaps this could be a deficiency disorder, which was very exciting. So I tried B12, and at the time I would send off these patients to get B12 injections from their primaries. And it turns out that they would come back and they would say, yeah, that B12, I get 2 good nights of sleep, and then I get 28 bad ones because we're injecting it once a month. And by this time, not to my knowledge, it turns out that Medicare had stopped paying for the B12 injections. And it was very interesting that I had 4 or 5 people that told me the same thing. So I'm giving my injections once a week. And I said, well, you're only supposed to give them once a month. And the patients would say, well, I feel so much better when I do it once a week. And I ultimately discovered that Medicare would only pay for the injections once a month in the doctor's office. And that's why we were told to give them once a month, not because it had anything to do with the biochemistry of B12. And you really need to be giving the B12 every single day. And this idea that we have to give B12 injections is actually incorrect. There's about 20 years of literature, European literature, that shows you could give a big dose of B12 as 1,000 micrograms, and it works just fine, and the B12 level goes up. So now what I'm doing is I'm taking all of these people, which is about 1,000 people, and I'm actually measuring their B12. So these people are sleep studies and somebody with daily headache, and now a bunch of other people are thrown in because I've been doing this for 4 or 5 years now. And now I begin to ask my epilepsy patients or my tremor patients or my stroke patients about their sleep. And I'm sending everybody for sleep studies. So I have a whole bunch of people with sleep study results. And I am now testing B12 in all of them. And one of my patients mentions to me, my doctor did my D level. She gave me D, it was very low, and my wrist pain went away. As I mentioned to you, I really wondered how these young women were having pain, because I didn't think anybody was supposed to have chronic pain in their 30s. So when she said that to me, I thought, oh, D, bone, maybe it'll do something. So I'm drawing blood anyway, and I throw in the D level. It wasn't an intelligence-based decision. I just thought, we're all desperate. Let's throw it in there and see what happens. So there's an actual uncontrolled trial of lab tests in a bunch of people who have bad sleep and various neurologic complaints between August and December of 2009. So I did B12 and D levels in every patient. And about a quarter of them, the really sick ones, had a low B12, but every single D was low. And the odd part was I happened to be doing it in August through December when the D should be the highest. So a very unusual clinical event happened in the week before Christmas of 2009, where two guys came in within a week of each other and said, you know, I've been wearing that CPAP device because you told me it would make my headaches better. And in fact, it did not. I've been wearing it a whole year. But the last time I was in here, you sent me a note and said for me to get the vitamin D and take 1,000 IUs of vitamin D. And within about 3 weeks, my sleep got a lot better. And then my headaches went away. And since two guys told me that, and that every single person I've done a sleep study on also has a low vitamin D, that led me to do a PubMed search over Christmas in 2009. And the first two search terms were vitamin D and sleep, and they were 0 hits. The second search terms were brain and vitamin D, and I fell into Walter Stumpf's literature. Starting in the early 80s, this guy has started to write that there are vitamin D receptors in this exact same part of the brainstem, like the nucleus pontus reticularis oralis caudalis. Like, who would even know about that? But this guy did, and he actually had articles that show they had specific brainstem localization in these specific cells in the reticular activating system that showed there were vitamin D receptors. So I found that absolutely fascinating. Also, if you look at the anatomy of how this particular stripe, because the reason why it's called oralis caudalis is it goes from the mouth all the way down to the feet, and it's organized by what part of the body you want to paralyze during which phase of sleep. So once you know about sleep, this organization is completely logical. So that means that D is playing a role in our ability to get paralyzed correctly. Okay, now that means that Chuck's original comment to me that we get the most paralyzed of all in REM sleep could actually be related to not having something that I don't even know how it works. This vitamin D, I know nothing about it, but it is affecting our ability to get paralyzed in sleep. And there are also vitamin D receptors in the clock function. Those happen to be in slightly different nuclei, the locus coeruleus and the substantia nigra. If you look at sleep studies through that lens, and you distribute the sleep studies based on what is the part of the brain stem that is failing, then you can distribute these sleep disorders into things that are clock related and things that are paralysis related and things that might be both going on in the same person. And it gives you a way of thinking about this. This is anatomy related, the anatomy that allows us to sleep normally and get paralyzed normally, not the anatomy of the neck. And it opens up all new ways of thinking about it. Now, what actually happened here is I fell into the very conflicted world of vitamin D. And I am going to spend a fair amount of time teaching you the history of vitamin D, because there is such a huge controversy, especially in Canada, where everybody's D is low, and therefore we should not worry about it. I want to teach you the proper lens to look through this, and it has a lot to do with the history of vitamin D. So it's not about bone, and it's not a nutrient. And I'll teach you why we've been thinking that way for 80 years and how it is hurting our patients. So if you'll recall, historically, we called vitamin D deficiency rickets. Nobody's using that word anymore. And there's been a twist to what rickets really meant. But here's what rickets meant in the 1700s through the early 1900s. You go back to the historic literature, this is the description of a child with rickets. A colicky baby or toddler, cries all the time, won't eat, won't walk, won't play, won't sleep. Poor tooth development, teeth that are breaking very late, very early dental caries, increased infections, picture tubes in the ears now. These are still the symptoms of D deficiency. But because everyone has D deficiency, we think that this is just what it's like to have a normal child. This is not a normal child. So oddly, historically, we've been taught that from the 1700s to the 1900s, the clinicians showed that sun exposure helped these children. In the early 1920s, they had bulbs that were just coming out that just emitted UVB light, and they showed that those bulbs actually shining that wavelength on children with rickets helped them get better. So there was an ongoing discussion about the fact that this was a disease of poor sun exposure. So here is an article written 100 years ago, November 15th, 1921, by Alfred Hess, who's a pediatrician in New York City. And I want you to pay attention to the title, The Prevention and Cure of Rickets by Sunlight. And yet his first sentence is, rickets is the commonest nutritional disorder occurring among infants. Like, why would he call it a nutritional disorder if sun exposure is not about nutrition? This idea set is so strange. So let me read you some of the things from his articles. So this was an experimental article where Dr. Unger and Dr. Hess had frequent short exposures to direct sunlight. The results have been most encouraging. The infants have not only improved in general vigor and nutrition, but the signs of rickets have rapidly disappeared under this treatment. It was found without exception that the signs of rickets rapidly disappeared under this therapy, including the diagnostic X-ray results. So when the X-ray machine came about, you could see that there could be many possible diseases that describe this child who's crying and won't do anything. And is really just completely cranky. Gee, have you ever seen any of those in your practice or in your home? And these cranky children could have other things. So when they find these specific diagnostic things on pictures that they can take pictures of, they get very excited about that. But not all the children have abnormalities of the bone. So here is Alfred Hess's final conclusions. Just keep in mind, he's giving you an answer for what you should do with these children. In New York City, I believe that the lack of sunlight plays a very important role in its development, and I'm strengthened in this view by the marked seasonal incidence which it evinces. And he goes on to say that it really shows up more in the spring and goes away by the fall. Then he says this heart-wrenching comment at the end: these clinical results, confirmed by laboratory experiments, show that although we have realized the importance of light in the growth of plant life, we have accorded it too little significance in the development of animal life. We have known that a growing plant cannot thrive in the dark, but have failed to realize that the same laws apply to growing animals. Infants have been the chief sufferers from this lack of understanding, and the development of rickets is one of its unfortunate results. This was a growing movement in the 1920s, and I want to read you one other article. This was written in 1925, so 4 years after Alfred Hess published this. This is by Joseph Garland in Boston. He's at the Mass General Hospital in pediatrics. Here's his description of rickets. Rickets, the most prevalent disease of early childhood, is essentially a disease of civilization. It is a result of man's attempt at self-betterment and the penalty he is paying for an indoor life and a diet of impoverished, preserved, and altered foodstuffs. Man was intended by nature to live in the sunlight and eat the food that came to hand. Instead of this, he has shut himself up in ill-lighted houses and accustomed himself to exist on foods that are brought from a distance, and for this very reason must be canned, dried, preserved, finely milled, and over-purified. You get the feeling that Weston Price is one of the people that's on this bandwagon. Now, I want to point out that he has one other really important description that was borne out again in COVID in India just recently. Rickets is prevalent in all the northern parts of the civilized world, recognized first in Northern Europe, where it has had a strong foothold for 3 centuries. It has followed the march of civilization to North America, and these 2 continents are now its strongholds. India, however, a southern country containing one of the oldest civilizations of the world, is not immune from rickets. The story of rickets there is interesting, for among the poorer classes who live on an impoverished diet, but whose women work in the fields and take their babies with them, rickets is unknown. Among the higher castes who marry their women as children and practice purdah, or the segregation of the women with their children permanently in darkened houses, rickets has reached a high degree. Even among the women themselves, osteomalacia, considered by some as an adult form of rickets, is common. The inference is obvious. The infants of the lower castes are protected from rickets by their constant exposure to the sun in the fields. The upper class infants are deprived of this protection and develop the disease. Now, we have known this for over 100 years. But despite this minority opinion, medicine decided this was really a nutrient deficiency and it would not change its mind. So because the bone X-ray had given special diagnostic help, in order to test this in animals, they used a bone assay. So they would actually do a bone growth assay in order to find this nutrient. So who did they test? Rats, of course. Rats, we use them because, one, we don't like them. Torturing them is less distasteful to humans because, in fact, we don't like them because they come into our house looking for food and they run around while we're asleep. So they are nocturnal animals. That means, actually, in order to become a nocturnal animal, you have to be able to find another way to get D. And it turns out that rats are able to use a much older form of vitamin D that's made by fungus. So they actually found the nutrient in the food, but it was actually a chemical that was much, much older than the D3 that we all make. And rats even make D3 on their skin. If you put them in the sun, they still make D3. But in order to become nocturnal, and think about the big advantage of being able to run around in the dark and eat other people's food. So it's a very nice niche, and they were able to have a vitamin D receptor that allowed them to use D2 pretty much equally to D3. And that's what made them great lab animals. You can put them in a cage, keep them indoors, and they still live for 1.5 to 2 years. So we found D2 first. It is not the same chemical as any other animal on the planet uses. And in fact, D3 began on this planet much earlier than animals. It actually showed up in flowering plants. So D2 was here when yeast and bacteria were there, but D3 showed up evolutionarily later. And there are some really important things about recognizing that this is a hormone. It was never a vitamin. It is not a fat-soluble vitamin. It's not a vitamin at all. It is a steroid hormone, just like estrogen, testosterone, progesterone. All of those sex hormones are made from cholesterol. Vitamin D is made from cholesterol on our skin. The definition of hormone is that it's a chemical that affects multiple different organs to produce behaviors that are survival advantages for that animal. So if you take estrogen, for example, there are estrogen receptors in the brain, in the uterus, in the ovaries, in the bone, in the liver, in the colon, in the skin, and even in the salivary glands. That means these hormones have different proteins that are expressed at different organs. And what these steroid hormones all share is that they have hormone receptors that are in the nuclear DNA. When you hit the receptor, depending on which organ it is, it produces a specific protein that's unique to that organ. So why is it important that D is a hormone? Because animals actually do lick their own D3 that they produce on their fur. That means most of the animals on the planet, except us and pigs, most of them have fur. They have fur or scales or feathers. That means those of us who are bald are the only ones that are actually absorbing the D directly through our skin. And to some extent, that may have actually given us an advantage over Neanderthal. If you're not in the habit of licking your fur, you will not actually grow as well or thrive as well or be as fertile. So our current use of the word vitamin means that people are still saying salmon is a good source for vitamin D. It's not a vitamin and it's not in the food. If you say that salmon is a good source of estrogen, well, there is salmon estrogen in salmon. But is that a good source of estrogen? Is that the way the body uses estrogen? No. There are sources that come from food, but that is not the source that we use. So this confusion between vitamin, nutrient, and a hormone that is made by following healthful habits, i.e. going outside, has left us with confusing habits when we treat our patients. So instead of saying you should never take a specific dose of vitamin D, you should always follow your blood levels, because every single hormone has a specific blood level. We are telling people blithely to go to the pharmacy and buy something. So if I am to tell a patient, gee, Joey, I think your blah, blah, blah is related to thyroid, why don't you just go down to the pharmacy and buy yourself some thyroid hormone? I'll see you back in a year. Most lay people over 20 say things like, wait a minute, my aunt got all screwed up and her hair fell out when her thyroid was too high. And then she was really cranky when her thyroid was too low. Even lay people know that hormones have blood levels, and they tend to want to stay in a homeostatically maintained middle ground. Too much is bad and too little is bad. And unfortunately, the science of vitamin D has gone way ahead, while we in the clinical side have completely ignored the science. There are vitamin D receptors all over the place. It turns out that this is old news, because starting in 1979, Walter Stump, who was actually in the big lab at the time, DeLuca's lab was the main lab that was studying vitamin D. In 1979, there's an article that says the targets of the vitamin D receptors for D3 are in the intestinal tract, the stomach, the kidney, the skin, the pituitary, and the parathyroid. This is just one of hundreds of articles that Walter and other authors have shown. So back in the 80s, 1989 is the third reference, vitamin D, light, and reproduction. Walter is writing about the fact that infertility will result when vitamin D levels go too low. Here's another one, light vitamin D in psychiatry, 1989, the role of vitamin D in etiology and therapy of seasonal affective disorder and other mental processes. The last one, salivary gland epithelial and myeloepithelial cells are major vitamin D targets. The actual root of the tooth has vitamin D receptors. Vitamin D sites of actions in the brain in 1987. He's writing about all of these different sites, and he's putting together a logical framework in which to see this hormone. So he was an endocrine chemist and a neurologist, and he started with estrogen receptors in the brain. And then he moved on to vitamin D. And he actually clarified this in the early 80s. There's a winter D state where the D is low and we are dormant. Just like the trees lose their leaves in the winter, we hibernate. UVB wavelength is absent in the winter sunlight. So this is an evolutionary thing that started millions of years ago that allowed for animals who move away from the equator to actually make it through the winter, like where you guys live. There's a summer D state where there's a higher D where we grow strong and we're active. It is not a fat-soluble vitamin any more than estrogen or testosterone are fat-soluble vitamins. It is not stored. If we stored it, we would never have a different state in the winter than we did in the summer. So everybody says we make it in the summer and use it in the winter. That's crazy. That means we would never be able to hibernate. No, there's a winter D state and a summer D state. And it was clarified 30 or 40 years ago that our metabolism, i.e. our ability to direct our calories into fat or into activity, our fertility and our sleep were all run by this chemical state. And winter D state means get fat and hibernate. So that kind of says our global population has been in permanent winter for the last 30 years. It's not too surprising that they're all obese and have these terrible medical problems. And once the D becomes lower than 30 for long spans of time, the brain actually forgets how to sleep. It loses the neurotransmitters that are necessary to have normal sleep. So it's not that surprising that D is linked to sleep. It was meant to be between 40 and 80 in terms of the level, And now it's globally below 30. And we're going to talk a lot about what the outcome of that is. So in 2012, Walter and I published an article, and I had a very simple focused question. If every single person in my practice who has an abnormal sleep study also has a low vitamin D, is it possible that there could be a vitamin D level, not a dose, but a level that would give us a better sleep? So all I did was ask my patients, hey, how's your sleep now? And they would say, still terrible. And I go, oh, well, let's set you down for another D level. I had no idea what I was getting into. I was completely naive of this hormone issue. But over time, it became quite obvious that when they got over 60, they came back and said, my sleep is better, you know? So we're all focusing on the sleep. You must understand when you read the D literature that every author has a lens through which they're looking. If you're someone who's about renal failure, you're going to look through that lens. If you're someone who's interested in bone, you're going to look through that lens. I am completely focused on sleep. I don't care about supplements. I'm not interested in vitamins. I am interested in, is there a way to give my patients better sleep? And it was very obvious that 60 to 80 was the range that gave them better sleep. The upper limit at 80 is actually documented through early studies in the 50s and 60s in lifeguards, where they were able to show that just using sun as the only source, no supplementation, they were unable to run the D over 80 in a normal biologic way because there were already inherent chemical changes that would happen that were related to heat and to sun exposure that would not allow the level to go over 80. Now, you can easily go over 80 by using supplement now, and most people are going to be really sorry. It may not be right away. So 60 to 80 over the last 12 years that I've been doing this has consistently been the place where most people have better sleep. Keep in mind that this does not mean that 60 to 80 is ideal range for humans. This is the range that's needed in order to give better sleep to someone who has been so screwed up for so long that they've developed a sleep disorder. We were not made to have sleep disorders when we're 25. We were not made to have sleep disorders until we were in our 70s, when our D, this is keeping in mind when we lived outdoors all the time, even in Canada, our D was not supposed to go down and stay down until we were in our late 70s. That means if you want to talk about an ideal level of someone who's never lived indoors and has never had a sleep disorder, that's probably a different level. So that's a summary of D. It's complex. If you want to learn more about it, how to use it, I'm happy to teach you more, but there's something that's even more important than D, because it was not D alone. So for 2 years, we're using D. We're all finding out that a good level of 65 in the blood led to better sleep. And then we all start to fail and bad things start to happen. So CPAP had also failed. So CPAP, my patients were like, oh, I feel so much better. I'm on 1 medicine for my hypertension now instead of 3. I've stopped all my oral hypoglycemic agents. My pain's better. And then by year 4, they're saying, you know, the CPAP, I still wear it because I can't really sleep without it, but I just don't feel as good. I'm back on my diabetes medicines, et cetera. So we're using it as a patch, and D's behaving the same way. Now I've got a D level of 65, my sleep isn't as good, and I've got this weird buttock pain where I can't sit down at the end of the day, which is so peculiar that I don't even go ask my doctor to take an MRI because I know they'll laugh at me. And my patients are coming back, not infrequently, with pain complaints. They're saying, look, I came to see you for my daily headache. Now my joints hurt, and I just want to know, is this possibly related to this vitamin D stuff we're doing? And I don't know. I have no idea, and it's making me very uncomfortable. And 2 of my patients come back with the same complaint of burning pain in their hands and feet. This turns out to be the same kind of pain and the same etiology as burning of the mouth and tongue. Burning in the hands and feet is very unusual. I am a neurologist. I have a neuropathy as my subspecialty, and I have been seeing subspecialty neuropathy patients for 25 years. And in that time, I've had maybe 2 patients come with burning in their hands and feet. I now have 2 patients who've been seeing me for daily headache. They're in their 40s. They do not have diabetes. They are already on B12, which was the major thing that helped burning in the hands and feet, in my experience. It frequently didn't cure it, but it helped it. They're already on B12 and I have no answer for them. So they're both complaining of burning pain and I'm trying to avoid their questions because I don't know what to do about it. But I'm suspecting that something is related to this D exposure and that now there's a new deficiency. So my concept in the background, because I'm so focused on sleep, is I don't care if somebody sleeps for 12 hours. I want them to feel better in the morning. So I want the product of excellent sleep. I want to feel better. That means I want them to stay in the deeper restorative phases of sleep to make more repairs. If it turns out that more repairs are linked to the building blocks of repairs, which are all of the B vitamins, is it possible that by making them sleep better, I've actually used up some B vitamin stores? So at this point, a patient brings me a book. Now, they're also bringing me crystals and essential oils and all this other stuff that I don't care about. And I try to be polite, but frankly, I'm still not into vitamins because I know D is a hormone by now. She brings me a book about pantothenic acid. And the reason why she brought it was because the author, who's writing this in 1998, says that I'm giving this pantothenic acid 400 milligrams. I took it and my joint pain, she has rheumatoid arthritis. My joint pain got better. I'm giving to other people who have rheumatoid arthritis. And not only does their joint pain get better, but their sleep gets better. And the woman brought the book to me because there were references about this. So the references that are small, done in convicts in the 1950s are really creepy. And they force-fed these convicts with tube feeding that wasn't really even made of real food. And they blocked pantothenic acid with a specific blocker. And after using this blocker, in only 2 weeks, they produced the following 4 things: burning in the hands and feet, insomnia, belly complaints, and a funny puppet-like gait. Now, I have 2 patients with burning in their hands and feet. So when I read this, I was very excited about that. This also implies that Mr. Herndon, who has that funny gait that isn't Parkinson's disease, that I may have actually worsened what he had by giving him D, improving his sleep, and using up any B vitamin stores. Now, if you'll recall, our dogma at the moment still is you can't hurt anyone with B vitamins because you pee out the excess. That is absolutely wrong. We don't have any stores of B vitamins. That's also absolutely wrong. And this is how I found out. So I went into the vitamin store, bought 400 milligrams of pantothenic acid, because that's what it says on the internet. And that's also what it says in this book. And while I was there, I was thinking, you know, I don't know much about what I need to know about, which are these B vitamins. But I remember from medical school that we were told if you give one B, you should give all of them. So I'm standing there at the B complex area and I find this stuff called B100. And B100 is actually a proprietary, that means doesn't matter what brand you get, it's got 100 milligrams of thiamine, 100 milligrams of riboflavin, 100 milligrams of niacin. I am also not handing out vitamins to anyone. I am actually recommending that they go and buy them. I want to know that what the doses are of these 8 chemicals, which is frightening to me and really, frankly, overwhelming. Now, what then happens is I'm taking a total of 500 milligrams of pantothenic acid because I'm taking 400 milligrams of B5 and B100. And within the first week, so I only give this recommendation out to my clients or my patients for 1 week. In that 1 week, my restless legs goes through the roof. So starting in the morning, I have restless legs and I have restless legs all day long, which makes it obvious to me by Friday of that week that there is a dose effect. And just like vitamin D, what they've written about in the routine vitamin literature is actually incorrect. So now I'm suspecting my patients are going to come back and yell at me. And in fact, that's what happened. So there's only about 40 people who I've recommended this to. And what they come back and say is the total opposite of what the woman wrote in the book. They took the 400 milligrams of B5 plus the B100, and they got agitated and they couldn't sleep at all. And they often use exactly the same phrasing. They would say, I got all revved up. I only took it for 2 nights. It was terrible. That means that pantothenic acid has huge power in sleep, but you have to get the dose right. Now, several of the people did exactly what I did. So when I started to have this terrible restless legs, what I did was I stopped the 400 milligrams of B5 and I just took the B100. And oddly enough, my sleep got better and my butt pain went away in a day, which was really peculiar. As the patients start to come back, they start to tell me things like, one, I'm going to fire you because you should have known that this stuff would make me have insomnia. But some of them stopped the 400 milligrams and just took the B100 and said the same thing that happened to me. I stopped the 400 milligrams, I'm taking the B100, my sleep got better, and my pain went away in 1 or 2 days. That to me was just mind-boggling. Now, I told you that I suspected that there may be painful conditions that might be related to our ability or our inability to get paralyzed in sleep. And it turns out that B5 is a major player in that area. So, Maria Skalska, if you could turn off your video, that would be really helpful. So it turns out that there were enough people that B100 added to D had such a dramatic improvement in their sleep and their pain that we found out something really important. One, B vitamins are not something that you want to mess with and just think that we'll pee out the excess. That is not true. And also, B5 is currently described as being in every food. Well, if it were in every food, then if you ate 3 avocados or none, you would be able to sleep or not. That means that B5 that we took as a supplement went right from our belly up into our brain and made a chemical that's kind of like the stuff that we use, the amphetamine-like things that increase epinephrine and norepinephrine. They make us agitated, they make us unable to sleep, and there's a specific dose requirement. And somehow, for some reason, my patients needed something close to 100 milligrams instead of the 400 milligrams in those rheumatoid arthritis patients. Also, the 2 gals with the burning, gone in 2 days. That's another support that what was developing here was a B5 deficiency state. And I think it's based on the fact that we were using more Bs in order to make more repairs while we were sleeping better. And there is a lot of literature already about B12, B1, which is thiamine, B6, which is pyridoxine. Unfortunately, there's no literature except mine about B5, except that when you learn more about what B5 and D do, you can actually learn that the literature says that B5 and D are involved in making acetylcholine, which is pivotally involved in our ability to get paralyzed and our ability to transition through the sleep state. So the literature is there. It's just not phrased in the way that B5 deficiency causes insomnia. So the first question is, why would they become B vitamin deficient? We have been taught that the B vitamins come from the food. So the next piece is, my patients haven't had a change in diet. They all have the same diet they've had for years. The only thing that changed is their sleep got deeper when they took D. So the questions that remained at that time were, why were they B deficient without a change in diet? Do the Bs really come from the food? Why did it show up at 2 years? There was a time frame that was very long. Are there really B5 stores, which is what that would suggest? I used up my B5 stores after 2 years. So here's what actually happened. I start to read about the B vitamins. I know nothing about them because I've been brainwashed into thinking they're not important. And I start to read the review articles, and it says things like, oh, thiamine has a colonic bacteria source and a food source. Riboflavin, colonic bacteria source and a food source. So the people who are writing about this are really not brave enough to say, gee, there are 8 things called B. They all are made by bacteria. Could it be that these 8 things, why are there 8 things called B? Like, that's a really good question. There's 8 things called B, and then C, D, E. Could it be that way back when, it turns out this is actually part of the story, in the 20s and 30s, these chemicals were all isolated as bacterial growth factors? Yes. So somebody way back in the past actually knew that all 8 of these are coming from the bacteria that are growing in our intestine. I happen to know that many of my patients have IBS and that irritable bowel syndrome showed up in the 1980s, along with sleep disorders, chronic fatigue, fibromyalgia, autism, ADHD, all the things that we who trained before the 1980s thought were kind of bullshit diagnoses because nobody came out with an answer. Like, what is fibromyalgia anyway? The things that we didn't have any classes about in medical school that have shown up since then that have actually not been explained have all been kind of sitting out there as physicians were wondering what the etiology of those could be. So now let's learn a little bit about the bugs, because it turns out that actually we all get our 8 B vitamins from our intestinal bacteria. Now, this was a hypothesis when I first wrote it, but there are several other articles that have the same way of thinking that have examined this question from different directions. So in 2012, when I'm suffering through, oh my goodness, what's wrong with my patients? Here's what we knew about it. There are 4 basic phyla in normal, healthy humans. In outdoor living moms, little kids are spontaneously colonized by these 4 phyla because of the D that's coming from the outside living mom's breast milk. Why is it a foursome? How do they get in there? It turns out that there are separate reports saying that certain of these B vitamins are made by certain specific bacterial strains. Could it be that the 4 phyla all require D and a B vitamin? They all produce at least one B, and they require a B in order to grow. If that is true, then I'm sitting here with all these patients. I've just given them great doses of D. They've got lots of D in their belly. But the thing that's weird about that is D by itself did not bring back the healthy bacteria. But what if they actually also required these other B vitamins? And in fact, the B vitamins were all described as bacterial growth factors in the 1920s and 30s. We were first learning how to grow bacteria in a petri dish. And it was after those growth factors were reported, we began to think, oh, well, maybe normal humans need growth factors too. So I'm now giving my patients D plus B100. That means I'm making a B soup in their intestine that should actually feed the normal healthy bacteria and cause them to grow back as the predominant foursome. And that is exactly what happened. Now, as I'm telling my patients that I think that this might happen, I started to get really worried because if you'll remember, when they were on 500 milligrams of B5, they all got very agitated and couldn't sleep at all. So what I started telling them was, hey, if I'm right about this, and this additional B100 means that your natural bacteria come back, we're thrilled about that because they are really the only people on the planet that know what doses these 8 chemicals should be in. But on the other hand, you're going to have to stop the B100 that I'm giving you because you're going to be on double the dose. So I said, if your pain comes back and your sleep disorder comes back, you have to stop that B100. And that is exactly what happens. And you have to take the B100, or in people who are less sick with less of the effects of a microbiome that's ruined, B50, you basically have to give all 8 in larger dose plus D and take it for 3 months and then stop the extra Bs because our biology came second. First came bacteria, then came fungus or yeast, then came lichen, and then came multi-celled organisms. And even little single-celled paramecium envelop a certain kind of bacteria that makes riboflavin, and they enslave that bacteria to get that kind of growth factor. That means we really only need additional vitamins until our microbiome is back, because our biology was built on top of what the supply of this foursome of bacteria supplied for us. So it turns out that D is just the mechanism by which we lose our microbiome, and returning the healthy microbiome is really the most important step. And probiotics are not the answer. Otherwise, they wouldn't be selling so much of it. You take it once and your bugs will be all fixed and you never have to take it again. Probiotics means dead bacteria that come back to life when you throw them down your belly. And I was paying $65 a month for those things. those bacteria, if you do not supply the growth factors they need, will not be self-sustaining. And the normal situation for humans and every other animal on the planet is that their bacterial supply is self-sustaining for their lifespan. So provide what the bacteria need. This is also what fermenting foods do, okay? These bugs, when you do something like make a fermented food, what you're doing with that is you're letting it rot. That means you're letting bacteria grow in there, and the bacteria are growing. A lot of times they make alcohols or things that have a peculiar taste like vinegar, but they also are producing these bacterial growth factors that they share with one another, and then we eat the fermented food. So there's a separate concept, which is prebiotics, which means we feed the bacteria what they need, and then they feed us, okay? Once you have the healthy foursome, then comes the manipulation of the healthy foursome to be even healthier by the foods we eat. So how did I know that their poop bacteria came back? I am focusing on their sleep. Everybody at this point was able to tell me, I did really well for the first 3 months, and then the last 2 months I've been terrible. And over time, I began to realize, okay, it's 3 months. That's the span of time we needed. And then you have to stop the extra Bs because your sleep disorder will come back. So healthy bacteria are self-sustaining. It is not antibiotic use that's changed to give us IBS. And I say that for two important reasons. One, my generation and the generation before me, from the middle 40s of World War II until the early 80s, there were a lot of antibiotics being used, but IBS did not show up until the 1980s. That means irritable bowel didn't start to be a diagnosis, and there were many other diagnoses that showed up until the D started to go low. The second point is we got antibiotics from growing bacteria. So if you'll remember, Pasteur grows these bacteria, and then somebody notices that little hump of little white bacteria with little black tips has this clear zone around it. And somebody looks at the Petri dish and says, hey, I wonder if that guy is secreting some chemical that's killing his competitors. And then we, take a chemical out of there, and that's where penicillin comes from. That means all of the viruses, fungus, and bacteria that are coming back as we do this procedure. And they start in the intestine, but they then move into the mouth, into our sinuses, in our ears, on our skin. There are specific species that like certain parts of our bodies, in our armpits, in our nose, in certain areas of our face where there's certain endocrine products that they like. Those carpets or clouds of those organisms are actually producing antibacterial, antiviral, antifungal chemicals that protect us. The current view in the GI literature is that us, so the most important article to read about this is one called Me, Myself, and Us, and it was in the Economist Journal at the time. I just started reading the review articles, and it really goes over the main ideas of the GI literature, such that those organisms are not exactly human, but they are a part of our body. That means if you look at a normal child, they look fine, but if they don't have a normal microbiome, they aren't really normal kids. They don't have a normal supply of the chemicals that they need to develop in utero or in early development. So taking antibiotics once you've corrected your irritable bowel syndrome, or even if you have no complaints of irritable bowel and you want to sleep better or feel better or heal something that's wrong with you, bringing back the normal microbiome is the most important step. Then once that happens, you can take antibiotics. It won't hurt them. They already are used to having antibiotics around. They make them themselves. It will change the consistency of your stool, and it will change the population for a while, but this is what the appendix is for. The appendix is our library of the actual colonies of bacteria. And surprisingly, about 1.5 years after I got my bacteria to come back, I got appendicitis, which is not actually a disease of 62-year-olds. It is a disease of teens and 20s. Nowadays, we are saying, oh, the appendix is at a 90-degree angle because if you poop everything out, you still have all these, it's like your little memory machine of all your colonies, and they go out and recolonize your gut. And nowadays, we're not taking the appendix out. They took mine out, but now we aren't. We're just treating with antibiotics, letting it calm down. So that means when your D goes low below 30, which is most of Canada, and stays there for prolonged periods of time, the thing that really makes people sick is losing their microbiome. So this I published by myself in 2016, and we're going to go over the details of the chemical events that happen once you don't have this B supply in much more specific detail so you can recognize the diseases that are walking into your office that are actually manifestations of this combined deficiency state. So you're not here to cure IBS, but you're certainly interested in the mouth microbiome because you're really smart and you know that the primary process of periodontal disease and dental caries and all of the things that are just primary dentistry in Canada are related to vitamin D and the microbiome of the mouth. So how do these D and Bs impact sleep, your dental practice, infection, inflammation, autoimmunity, and the autonomic nervous system? Because you're a sleep dentist, you also know about how important the autonomic nervous system is as a monitor of what we're doing in sleep. So the first question would be, what was in this B5 and why did it make my patients so crazy? What made them have insomnia? How is it this innocent looking vitamin that's sitting on the shelf could turn someone into someone who was revved up? It's like, I just took meth. I mean, that's weird. These are supposed to be completely innocent chemicals. They're not. But I really didn't know what chemical it was that was causing that. I would tell my patients, well, you know, if we go too high, this is going to make you revved up like coffee. But I really didn't actually know what the chemical was that this B5 was making, but it sure seemed to make it in the dose that was given. So why did my patients get insomnia with 400 milligrams of B5? What was different about my patients than those patients that the woman was giving this 400 milligrams? Was there something? The only thing that was different, as far as I could tell, was these are the same people that are in her book. I'm not treating her population, but otherwise they're the same. The only thing that's different is they all consistently have a higher D level than the people that she's treating. So what does D make in the sleep switches? And it turns out that we actually know when D hits those little receptors in that set of sleep switches in the back of the brainstem, somebody has actually investigated Walter's findings. So Walter found that there were vitamin D receptors in that little stripe of cells. And they went the next step further to say, when the vitamin D hits that receptor, what do those cells make? And they actually make choline acetyltransferase. So here's an article from 1986 by Christakos, who's somebody who followed Walter's articles and did this experiment. 125 dihydroxy vitamin D3 treatment results in increased choline acetyltransferase activity in specific brain nuclei. This was done in rats. That means we actually know what was different about my patients. They've been for 2 years making a lot of choline acetyltransferase, and it's all sitting in those cells. And why would I be interested in this? So I want to prompt you with acetylcholine. Like, none of you should really have much of anything bounce into your mind when I tell you that name, except for perhaps you remember the neuromuscular junction and that acetylcholine is used to move the muscles. But it turns out that acetylcholine is actually very important in the brain. Oddly, as a neurologist, when I read acetylcholine, and that B5 becomes coenzyme A that makes acetylcholine in the brain, I did not have any clear idea of what symptoms or changes should be associated with that. I could think of the neuromuscular junction. And what I learned was, I, as a neurologist, learn what these different neurotransmitters do based on the drugs I give out. So I knew about serotonin because I would give serotonin reuptake inhibitors and people would get happier. And I know about dopamine because I give it to Parkinson's disease. But it turns out there are no drugs for acetylcholine. That's not completely true. There is one, nicotine. In fact, if you took primary pharmacology in dental school, you would have learned about acetylcholine in these cholinergic nerve cells that used acetylcholine and would hit nicotinic receptors and muscarinic receptors. That means that the only drug we've ever had that's a direct acetylcholine agonist is nicotine. Now, as I find this out, and again, I'm typing it into Google, when I type in what is B5 or B5 becomes coenzyme A. So what does coenzyme A make in the brain? It says acetylcholine. And then in these amazing textbooks that are from the veterinary literature, not from human literature, it says acetylcholine is needed for alertness and focus during the day, and to be able to transition through the phases of sleep at night and to do REM sleep at night. And I'm looking at this going, this is really weird. Why aren't any of the sleep experts talking about it? Is it just because there are no drugs? So here is the actual equation. So what's been happening in my patients for 2 years, there's making this enzyme, choline acetyltransferase. And this enzyme is looking for two things: choline, which comes from the diet and can be deficient in some people, and another thing called acetyl-CoA. Acetyl-CoA is actually something that requires B5. So you can make all this enzyme as much as you want, but if you don't have these two raw materials, you can't really make acetylcholine. Now, it turns out that the next piece is to learn that, oh, B5, what's it doing? It's making coenzyme A. And that book that I told you about, that was about the rheumatoid arthritis patients, said coenzyme A is necessary to make cortisol. And because that was one of the first findings back in the 70s, there were a whole series of clinical trials done in rheumatoid arthritis patients, lupus patients, Sjogren's patients, trying B5 as a treatment for these autoimmune diseases. The problem was they didn't have much success because they didn't recognize this connection between the microbiome and the fact that they're not just deficient in one B. They're deficient in a whole bunch of things. They're deficient in D, and they're deficient in a whole array of Bs. And in order to get that autoimmune disease to reverse itself, you have to get these separate building blocks into a body that is sleeping. The bricks don't build the wall. The bricklayer builds the wall using the bricks. That means nothing happens if you give people vitamins and they don't sleep. So coenzyme A turns out to make 100 different things in our body, which the confusing part about that was, one, my patients did not come back and say, I couldn't move my muscles. So if the B5 is directly making acetylcholine, why didn't it make their muscles stiffen if that's where acetylcholine is active? And why didn't it do 100 things? Why did it only make them revved up, anxious, agitated, and not able to sleep? That sort of suggests that B5 becomes acetylcholine without any sort of a controller in only certain parts in the body, only certain chemical uses. Okay, now, choline comes from the food, the B5 comes from the bugs, and now these people are either perfect with wonderful sleep when you get the D and B5 perfect, or they get really agitated and anxious, or anything they had before that now when you're looking through this lens, you'd say, oh, those are things that happen when you're B5 deficient because, oh, 5 years ago, you started on vitamin D because your doctor told you you had mild osteoporosis. And now 5 years later, your D is 60. And oh, it's true that your sleep was a little bit better. But this odd thing happened in the last 6 months, which is your joints start to hurt all over and you're now seeing a rheumatologist. So there is a big connection to starting D, and all around the world since COVID, many people have started D. If you start D and you do not correct the microbiome, you will go through this series of events I have just spoken to you about. Now, the current dogma in all of the internet is that pantothenic acid deficiency doesn't exist because it's in every food. And that is absolutely wrong. There is no pantothenic acid in any of the food. So I just spent the last 12 years going through all the literature, trying to figure out how this incredible mistake happened. Coenzyme A is, in fact, all over the place in the food. But it turns out if you can't take coenzyme A to become B5, which it doesn't appear that there are any mechanisms for humans to do that, or any other animal for that matter, The only source, or it's the bacterial source of B5. And it appears that that particular bacteria, even though it's not yet been named, needs D as a cofactor, and it needs to hang out with its other 3 phyla of bacteria, and none of the Bs work by themselves. It is always the same dogma I was taught in medical school. If you give one B, you really should give all of them. And this deficiency is global and very common and manifests in many ways now. So B5 deficiency is common. Now, the weirdest part for a neurologist is this whole idea that you could become vitamin deficient and that could produce a neurotransmitter deficiency is still something I really can't wrap my head around. It's a very weird concept, but that appears to be the case. So I'm going to show you all the diseases that are associated with low D, loss of the microbiome, and basically an acetylcholine deficiency state. The importance of this is to recognize, oh, that's wonderful biochemistry, but what does that have to do with my patients? So getting paralyzed as sleep is one of them, but the autonomic nervous system dysfunction that we've seen where they're in inappropriate fight flight could also be seen as a deficiency of the parasympathetic side, which is where acetylcholine is used. So is it possible that my patients who have fight flight all the time and are sitting on my examining table with a heart rate of 110 actually have a deficiency state of the rest and digest side, the parasympathetic side, and that is the case. So I had published that in 2016, but here are the other acetylcholine deficiency. These are from other authors that are writing about ADHD. ADD are actually acetylcholine deficiency states. Parkinson's disease has an acetylcholine deficiency state before the dopamine deficiency. Autism is felt to have an acetylcholine deficiency state, and they're actually using nicotine patches to treat it. There is something called the acetylcholine anti-inflammatory pathway that's also playing a role, where acetylcholine is actually an anti-inflammatory chemical being secreted by the T cells. So why do you care about acetylcholine? Because it's all over the place, you, your family, and your patients. And the most important thing to remember is D by itself does not bring back the microbiome. You need to do that as well. The microbiome is also responsible for absorbing small charged metals. That means they're deficient in other things. And the microbiome actually provides the raw materials that become the endocannabinoids. That means the development of the nervous system, both in utero and in childhood, are tightly linked to mom's microbiome and the child's microbiome. So unfortunately, all of these diseases are old. They are all diseases that we've said are old people's diseases. Old people's teeth just fall out. Old people have fungus in their toenails. Old people just fall down. Unfortunately, these are all now moving into very, very much younger populations. Those of you who are interested in sleep disorders in children, prevention is so much easier than treatment. If we treat the mom before she's pregnant, her microbiome will then supply the bees properly so that the development of the fetus is normal. So D by itself is linked to infertility, preeclampsia, etc. But the B vitamins in the mom's belly are also playing an important role. And those prenatal vitamins are not actually supplying what the baby needs in the doses that they need. So normal fetal development also needs this. Mouth breathing is also directly linked in various ways to the B vitamins and D through nasal breathing. Mood disorders in childhood, the same, up, up, up. Together, as we provide our various parts of this, so we work together to try to make kids better. This is a very long, difficult process. It's not here, like, tell me what dose to take. Because of that, I have a workbook on my website. I have videos to help coaching through childhood and pregnancy. When you buy the workbook, you buy into the program, and we have question and answer sessions, and we have courses. So if you would like to learn about this more in depth, that course will be given on December 2nd. We will record it if you're not able to attend live. I've actually provided you a special coupon to get a $50 discount. And I would love to have anybody who's interested in this to attend that course. Once you do that, I will also help you in figuring out how you can get D levels done in Canada. So now I'll stop and answer any questions that you're still hanging around and still want to ask. Thank you so much.